Good evening, everyone. My name is Judy Karaganya. I'm introducing our moderator of the day, who is Dr. Brenda Walaba, who is a consultant ophthalmologist and Nairobi County's chief ophthalmologist. Her training is a Bachelor's of Medicine and Bachelor of Surgery degree from Moi University, an M.Med in Ophthalmology at the University of Nairobi. She is a fellow of the College of Ophthalmology of East, Central, and Southern Africa. She's a Global Eye Health Clinical Fellow from London School of Hygiene and Tropical Medicine and a Clinical Fellow with specialization in glaucoma, medical retina, and cataract surgery from LV Prasad Eye Hospital in India. So very exciting. She's an ardent advocate for quality and affordable public eye health, especially in undeserved communities in the city. So I'd like to welcome you all and hand over to Dr. Walaba to take over. Asanteni and karibuni sana.
Thank you, Dr. Karaganya, for the introduction, and apologies for the delay. So maybe just as a preamble, today we are having a CME on low vision, and specifically low vision glaucoma. As we all know, the burden of visual impairment globally is quite high. We have more than 1.1 billion people who are visually impaired, out of which 43 million are actually blind. And from the RAB, which we did in Kenya just 2 years ago, we saw how many of our population are actually visually impaired. The prevalence is between 11 to 37%. And from the RAB results also, we observed that cataract, uncorrected refractive errors, and glaucoma are actually the major causes of low vision, or rather visual impairment, in our setup. So this forms the basis of our CME today. And we are so excited to have Dr. Nandasaba, who is a glaucoma specialist, and Dr. Zara Rashid to take us through this CME. So Dr. Nandasaba will start us off. I'll just introduce her. So Dr. Nandasaba is a consultant ophthalmologist and a glaucoma specialist working at Kenyatta National Hospital. She has a Bachelor of Medicine and Surgery degree from the University of Nairobi. She also has a Master of Medicine in Ophthalmology, still from the University of Nairobi. She did her fellowship in glaucoma at the University of Yamanashi in Japan, and she's had a diverse experience working both in the public and the private sector. So it's a privilege to have her today as our first presenter. Over to you, Dr. Nandasaba.
Thank you, Dr. Laba, for that good preamble and the introduction. So good evening, everyone. Welcome once again to today's CME, and thank you for making time to listen in. Apologies once again for the technical challenges at the beginning of our presentation. Now, a few months ago, I had a patient in the clinic who had come for low vision assessment as per the for medical assessment as per people living with disabilities guidelines. So I remembered him from many years back when I first came across him. We had just started our postgraduate training, and he had suffered a severe injury that had left him with loss of vision in one eye, and in the seeing eye, his vision was around 560. So in the course of the discussion, he talked about life after he was discharged from hospital, which really left me in thought for quite a while. He actually said he was in the house indoors for 2 months, and he was so scared of leaving the house because he couldn't see well. Life as he had known it had changed completely. And he only left the house after a good friend of his visited him and insisted that day he won't leave unless they've gone out for a walk. And that is now how he slowly picked up and started now trying to live his life again. And he has done quite well for himself, now doing motivational talks in schools, and he's settled down and he has children. But he also mentioned the challenges that he faces every day. He has difficulty crossing the road because he can't see too well and has to rely on good Samaritans. And he also said there was a time when he was walking and he fell into a manhole, and it took a while before he could be assisted. And he said such incidents has really scared him. And his story made me think about our patients in terms of what happens to them when they lost a significant part of their vision and we cannot correct it any further. Is there a way we can help them improve their quality of life? And today I just want to shine a spotlight on low vision, especially in glaucoma, and just start up to now start paying attention to the rehabilitative part of treatment, even as we manage our patients every day. So we all know glaucoma is the second leading cause of low vision, which is unfortunately irreversible. And this can happen because of either loss of time, patients present when the disease is actually quite advanced, or sometimes despite best efforts, we actually lose the fight and a significant portion of the optic nerve is damaged and patients develop low vision, and for some, they actually end up losing vision altogether. Low vision has the effect of glaucoma on vision is varied. It causes reduced visual field, it causes a decreased contrast sensitivity, reduced visual acuity, sensitivity to light, glare, and also the experience fluctuation in their vision. This loss of vision has a significant impact on various areas of the patient's life. They have difficulty carrying out daily tasks. They lose their independence. You can imagine right now you can be thinking, you probably might be thinking tomorrow is Good Friday, you want to go probably shopping, or you want to go and drive for a drive with your family. But for someone who has low vision, this is not an automatic decision that they make because of the visual acuity they have and contrast does not allow them to do these things freely. This also ends up isolating them from social events. It causes anxiety at multiple levels, whether at work, be it driving, and they also experience other added on health challenges like risks of falling because of poor visibility. Also, low vision changes the way life happens. You have to depend on others around you, and this can cause a strain in family relationship. The patient is suffering from increased dependency on others, and the person who's supporting them now takes on the caretaker burden and the challenges that come along with that. So we define low vision as a visual acuity of 20/70 or to 20/40 in the better seeing eye, or a visual field of 20 degrees or less, and this cannot be corrected with glasses or contacts. We also have a different definition that is also preferred by low vision specialists in terms of now trying to help patients, and the term has uncorrectable visual loss and interferes with daily activities, which the definition captures function rather than a numerical test result. And rehabilitation in low vision basically focuses on maximizing the patient's remaining vision, thus helping them to perform their everyday visually mediated tasks, and also helps them to navigate the environment safely and improve their quality of life. But now the question is, how often do we actually refer patients for low vision assessment and rehabilitation? There's a study that has been done, and I found the results quite interesting and startling, that actually only 10% of patients with low vision in glaucoma actually get to be referred to see a low vision specialist. The challenge, what causes this is as a result of multiple factors. First of all, loss of vision in glaucoma is gradual. And also vision fluctuates from time to time. There are times when patients can see better, and there are times when vision dips. So this brings about a challenge in terms of timing. Exactly when do we refer a patient for low vision rehabilitation? Then patients may not be very receptive the first time a referral for low vision is brought up. There's the issue of accepting the situation as is. They also have hope in terms of hoping vision will get better. So the first time the clinician will bring this up, it may not be immediately taken up. And if you don't take time to introduce this discussion again with the patient later on, it may actually fall off on the wayside, and the patient may not be able to benefit from low vision services. Then also consultation times are limited. There may not be enough time to have that discussion. And the other challenge that we face is that the number of low vision specialists are not many, or sometimes, interestingly, you may not know exactly who is in low vision, who we can refer a patient to. The other interesting finding in terms of low vision and glaucoma is that sometimes the specialists have a limited understanding of what exactly do low vision specialists do, and this can also have an impact on their belief in exactly what can be achieved for patients. So this talk is just meant now to highlight these issues. Right now we are aware, and we'll be able to refer in a more timely manner. Referral has no specific point, and as we had discussed earlier, it's more individualized when patients feel like the daily activities are now being interfered with. For example, for someone who, say, is a lecturer and has to do a lot of extensive reading, their timing for rehabilitation may be quite different for someone who doesn't have who doesn't need their visual in such detail, and therefore it's important now to have a discussion to know with the patient to know when to send them for rehabilitation. So when they go for low vision, the low vision specialist actually assesses the different activities of a patient's life, and so that they can tease out where the biggest challenge is. Refraction is done to determine best corrected visual acuity. Contrast sensitivity is done to establish exactly where the patient lies, and an assessment of visual field is also done. So once all this is in place, a second now discussion now comes up to establish a patient's goal, because we have different areas in our lives that depend on vision. So could the patient be having difficulty reading, or are they having difficulty moving around and moving around safely? They don't get injured or get fall. And also, are they having a challenge with driving? So once this has been done, then it helps determine which visual aids or devices and which technologies or behavioral changes will best address a patient need. So we have different types of low vision aids and devices, classified broadly as optical, which may differ from the conventional lenses that we have for spectacle correction, and we also have electronic devices. So optical low vision aids cater for distant, intermediate, and near vision. For distance vision, we have telescopes, which are of various kinds. We have the Galilean and the Keplerian telescopes. Then you can also have telescopes that are handheld. Others are mounted on spectacles, or they are clipped on spectacles. They can also be binocular or monocular. Point of focus, they can be fixed focus. The focus could be adjustable, or they can autofocus. Then telescopes generally make objects bigger and bring them closer to the patient, so they'll be able to see it in a bit more clarity. For near vision, we have the high-class spectacles. We have magnifiers that can be handheld or can be mounted on a stand. Some of them have lighting incorporated in it, or we have telescope system for near. Then we have the electronic devices, like we have electronic devices like video magnifiers that help magnify text and project it on a computer screen. We also have the closed circuit televisions, that is CCTV, the one on your right that the patient is holding. We have computers with braille, or we have software that can change text to speech. Then we had mentioned the areas of function, the different areas of function that need vision in everyday life, that is reading, driving and transportation, visual information, and mobility. We'll see that in a bit more detail later on in our discussion. So just as a recap, when we have a patient referred to a low vision specialist, low vision assessment is done, and then they assess the area of function, and the best, and with that now, the appropriate optical device, low aid devices are established. So when it comes to reading, patients with low vision and glaucoma experience difficulty in reading small prints. When they're reading, words may look like they're merging or running in together. They may have difficulty keeping their place on a page, like you're reading and then you get lost in exactly where you are. Then you also have reduced contrast. You have difficulty reading in dim light. You can imagine, say you've gone for dinner in a restaurant whose theme is low lighting to create their desired ambience. A patient with glaucoma and low vision will struggle reading the menu and they're presented with it. Then for those who have extended reading, they develop eye fatigue. So in terms of managing this, we have the spectacle correction. This can be high plus glasses. Then we can have visual assisted equipment that that enhance the visibility. We can have the magnifier that we have talked about, or we have the non-visual approaches that we have touched on. And this will be employed at different points. For example, if you're in a supermarket and you want to read, that is spot reading, a different device like a handheld magnifier may be appropriate. But if you're going to read lengthy documents, then you may opt sometimes to use softwares that convert text to audio. So this is just a picture that is depicting the various devices for reading, and also increased lighting on a document that a patient is reading also helps greatly. Also, in terms of reading, we have mentioned the sensory substitution using the software that will read a screen for the patient and convert text to audio. We also have apps on our phones. Some of them are free that now a patient can use to either read a label of an item when they're shopping. It can help read currencies. It can help recognize faces. And you can also have braille when you have to type out something. Then the other aspect that is quite a challenge is driving and transportation. Low vision will cause patients to struggle seeing road signs and reading them. They may have difficulty viewing GPSs that usually mount on dashboards when you're going to places that you're not familiar with. There's glare also from oncoming cars, especially if it's at night. Also during twilight and night times, or when they're driving through tunnels or in a garage where lighting is low, vision is also quite reduced. Depth perception will be a challenge. So with all this, driving becomes stressful. Driving is it's a skill that has a high cognitive load. You can imagine how our roads are like right now. You're driving, there's someone who's crossing the road, there are motorbikes that are coming from both sides of the road at a very high speed. And if you have low vision or you have contracted visual fields, this becomes a very stressful factor. The other challenge with driving in transportation, patients may not be willing to come out early in terms of the challenges that they're having, because some of them are afraid of being told to stop driving because either they don't have any other means or they're scared they lose their independence, or in developed countries which have very strict rules in terms of driving, their licenses may get taken away. So for this now, refraction is done to best correct their vision, and should they qualify to actually be allowed to drive, then and they need glasses, then the lens design would vary a bit. You can have driving glasses, which may be bifocal, but as opposed to bifocal that we use for reading, we have a lower near add, like say +1 or 1.5, to allow a patient to see the dashboard instead of the +3, for example, which now allows a patient to read finer details. Or you can opt to use single vision lenses instead of the multiple focus lenses because of the contraction in visual fields that this comes up with. Then also you may request or guide the client to drive only in familiar areas and in daytime, that is if they qualify to do so, and also to have a car with extra features like anti-collision features. And best, if this is not feasible, then you need to have the hard discussion with the patient and ask them to get an alternative model transport due to the danger they pose to themselves and to others around. We also have another aspect that is the visual information that we use in our day-to-day interactions. Patients have difficulty telling faces for people who are far, and most of them worry. You'll find in clinics they tell you, daktari nikikutana na mtu anafikiria nimemwignore, sitaki kumsalimia, and it actually stresses them. So we also find they have difficulty telling facial expression. Putting on makeup in the morning may be a challenge, or they may be losing part of their visual field. For example, the picture on the right part of your screen, you can see the children crossing the road. If you compare normal vision and a patient with glaucoma, you notice they're missing the different barriers on the road, they're missing the oncoming lorries on the road, and this becomes quite a challenge. So to manage this, a patient may have to learn scanning, that is to move their head around so that they can be able to capture the whole scene. They need to take advantage of increased lighting, whether it's inside a room or limiting activities to the daytime. We need to refract. They may have to learn to get closer to people or objects in order to see clearly, and also the use of telescopes. Then also mobility and safety. Patients, as we had mentioned, they have a hard time moving around safely. Crossing the road becomes an issue. And also when they're walking around in the house, they may bump into objects. They may miss steps and curves, have difficulty reading signs. And if they're caught out late and they're walking back home, they may also have a challenge with that. So for mobility, again, refraction to best correct vision, consider using single vision lenses. Then behavioral modification, they may ask patients to move a bit slowly. They may need to utilize their memory of an area. Say if they're visiting an office or they're visiting someone's house, they may need to remember the layout and use this a bit more. Then they have to scan for obstacles by moving their head around to see well the complete area that they're moving in. They have to wear fitting shoes with a stable heel, and should not be shoes that can slip easily. Then at home, they need to make sure that the floors are uncluttered. They need to either remove carpets or take them down to avoid tripping on them. Low contrast furniture like glass tables become a disadvantage in this case, and it's best that they are avoided. Then you also need to light up the house well, and then also have sturdy furniture so that should someone fall, they can be able to break the fall with the furniture. Then they also have the option of using smart canes or support canes designed for low vision, or use smart canes with GPS. Or sometimes they may need to ask someone for assistance. So this is just a picture depicting a smart cane, a white cane, and on a bigger level, some countries have come up with tactile pavements, which have a bright line that contrasts with the rest of the pavement that can guide a person with the low vision. Also, they have raised points on it where someone using a white cane can actually use that tactile information to know when they're moving and also to know when to stop. And we hope that with time our country will be able to incorporate this on our roads. The newer technologies that are coming up, we have the Google smart glasses that can help read people's faces and give an audio recognition information to the patient, or help read labels in supermarkets. So these are the newer technologies that are coming up. So these are my reference points for those who wish to read a bit more on that. I hope there's a lot to cover, but I hope I've been able to just tease your curiosity, and we'll be able to follow up a bit more on this. So at this point, I'll hand over to Zara, who that is her area of specialty. She'll be able now to clarify a bit more and also give her experience in terms of the patients she has managed. Thank you very much. Karibu sana, Zara.
Maybe before Dr. Zara comes in, I just want to thank you, Dr. Nandasaba, for the very insightful presentation. I think low vision is one area that, as ophthalmologists, most of us, maybe younger in the profession, are not so well versed. And at times when patients present to you, you really don't know how to assist them or maybe where to refer them to seek these services. So I think this is very insightful. So as Dr. Zara sets up, I would just request that if you have any questions, please type them in the chat box. We'll take up the questions at the end of the presentations, and then presenters can also respond to it. So as Zara sets up, I would like to introduce her. So Dr. Zara Rashid is an optometrist with a master's in optometry degree from Cardiff University in the UK and a PhD from the University of KwaZulu-Natal in South Africa, where she developed a model for screening, diagnosis, and management of keratoconus. Zara was actually one of the pioneers in setting up the low vision services at Kikuyu Eye Hospital and schools for the visually impaired in Kenya. She has been practicing for more than 23 years in the eye space and currently in private practice at Gertrude's Children's Hospital in Nairobi. She is very passionate about raising the standards of eye care for children in Africa, and she works closely with ophthalmologists. Most of us here know Zara very well and beyond to ensure that this is done. Welcome, Zara.
Hi, Dr. Alava, thank you so much for that. I might need the IT guys' help. I've actually, I think I had to do F5, didn't I? know, but I don't know how to pick my presentation.
Zara, try sharing. We see if it will come up. Hi, Zara.
Hi, sorry, I'm here. I'm going to start sharing again.
Okay.
Let me try this.
Okay.
So I click share screen. Then I go to entire screen. Oh, it's not allowing me to share. My share button is not coming. Let me try that again. I'm canceling. I'm sharing. Okay, then I click on entire screen. On your side, have I been enabled to share? Because for some reason, my share button is not.
Maybe you can just try to do what you did when you were trying to set up from the beginning. We can present that view.
So I did, so I just went to share screen, but right now, my share icon, my share on that is not coming up. So I don't know if Dr. Nandasaba stopped sharing on her
Dr.
side.
Nandasaba, yeah, she's not sharing. We can't see her.
See, if I show you mine, it's just not, earlier it was doing it. So I don't know if I'm not enabled on your side as the admin.
Is Mercy on the call? Could you just help us?
Yes, I'm on the call. It's enabled. I'm trying to check because on the icons down here, I can see start presenting and I've enabled.
Even says presentation is started, but I'm not able to share. That tab is just not allowing me to share. And I was able to share earlier.
Dr. Nandasaba, have you stopped sharing your screen? We can't see it though.
I've stopped sharing mine.
Okay. So I'm going again here, presentation, just not allowing me. Shall I email it to you, Dr. Walaba or Dr. Nandasaba?
You can email to Nandasaba.
And then you
can just try it.
You can try it on her side. Okay, guys, just give me some minutes. Sorry about this. I think we're all so used to Zoom.
To Zoom, yeah. Meet.
But somehow it worked earlier. I don't know why now it's not working.
So as we wait for Dr. Zara to set up, let's continue typing any questions in the chat box so that the presenters can take them up at the end of the CME.
Dr. Nandasaba, it's sent. Just check for me.
Okay, let me just check briefly. I'll let you know if it's come through.
I think something has worked.
Okay.
Can you see the screen? So maybe the IT guy can help me. I've actually done what he said. I've clicked on entire window. I don't know what you guys can see.
Put your first slide. We see if it will come.
Right now, I've got this sort of screen that says stop presenting on one side.
Yeah, that's what we can see.
Okay, hold on.
Yeah, yeah,
Yeah, good.
You got it?
yeah,
Okay, so
yeah.
then he said I need to do what? F5.
F5.
Okay. Got
Yeah,
it, guys?
got it. Yeah.
Perfect. Again, sorry, I didn't share my video, so
No worries.
thank you. Okay, so Dr. Nandasaba, thank you so much. You've made my work really easy because she's really covered, and it's really impressive for, like myself as an optometrist. It's really nice to see that ophthalmologists are now really taking this on board. And Dr. Nandasaba's knowledge is really impressive. So I hope this will rub off on all the other ophthalmologists as well. But generally, yeah, the main thing is that they have tunnel vision, as you can see here on the right-hand side. You can see what a normal view somebody sees as well, and then somebody with glaucoma generally, until it's very advanced where the central vision gets affected. But on my part, what I see, I get a lot of patients from ophthalmologists who are referred to me, and it's really the refraction that I find. I would say 50% of the referrals that come to me, I do a good refraction, and they get to about maybe 618, some 624, and they're quite happy with that. And they say, oh my God, you've taken me from 660 to 624. And I'm thinking, but I just did a simple refraction. So where is it that the optometrists we're working with, etc., the community optometrists, where are they going wrong? And those in practices, because really it's very, very simple. So one of the areas that I think the optometrists who are doing refraction could be missing out on is that either relying only on the auto refraction, and a lot of patients with low vision, they may not get a good reading on the auto refraction. They may get errors for various reasons in terms of their fixation, etc. So my tip for anybody before sending low vision patients, if any of the ophthalmologists are working with their optometrists, is to, just demand that they pick up their retinoscope. Because sometimes it's really unfair when you send the patient for a low vision assessment because it's an extra cost for them. The glasses can easily be done at your facility, but the optometrist has to really just pick up that retinoscope. And this cuts across all low vision patients. And then they have to take the time to do a good subjective refraction. I know phoropters are now sexy and everybody wants to have a phoropter, but really for this group of patients who have low vision, really you need to go back to just the basics. Just do a trial lens refraction. Put a trial frame on. They will tend to have eccentric fixation. So using a phoropter is not going to help. And then you have to use large brackets. Put a +4, put a -4. The sills, go with +1, -1 sills. So use really big steps so that you can then get to that. You know, sometimes I even let the patient turn the axis. And sometimes you can be really surprised that turn the axis and the vision can improve by 1 or 2 lines. So you really have to spend a bit of time doing a good refraction, and you can get really good results as well. And then I get a lot of patients with low vision that for whatever reason, could be financial reasons, etc., but they're still so very expensive progressive lenses. And really progressive lenses are very hard for even people with normal vision to use. And if you can see here at the bottom, the image that I have on the bottom right, you can see that by the time you're getting, I know there's some amazing lenses which are very expensive that come from Europe, etc., can have wider corridors, but patients are going to spend 40, 60,000 shillings on this kind of lenses, and they may still not be very happy. So my approach with a lot of low vision patients is to really use single vision. Bifocals are great, are sort of your in between, but you've got to, because bifocals are good because they have to see their food as well, right? If a patient is, whatever prescription they have for distance, they also need to be able to see things at near. They may not be able to see N5, which is okay, but they need to be able to see their food. So at the most, I would give them bifocals, but progressives I tend to stay away from. And this is just a simple example of a patient that Dr. Nandasaba had sent me. She's a 20-year-old girl. You can see her visual fields there, very, very tiny visual fields. And she said, well, I've tried spectacles everywhere else and they don't help. So I said, well, you know what, let me try a refraction and let me see what you can get. And she was really surprised, at what she could see. And you can see she's 6'12" and 6'9". And binocular near vision, I didn't even have to give her an ad or anything. She was 9'6". So just with a really good refraction, we can really help our patients. But at the same time, this patient highlights a very important point. Whenever we are talking about the definition of low vision, we're always thinking about visual acuity. And if we just think about visual acuity in this case, then you're going to say, well, this patient isn't low vision, and we shouldn't certify them as visually impaired. But really, she does meet the second definition of a visual field of less than 20 degrees in diameter. So she has a really, really small central visual field, which means that she does qualify to be classified as low vision. Now, saying that, there are people who will abuse the system. They will come in with 6'12", 6'9" vision and will want to be certified low vision. But it's really important that we try and then, with our visual fields, make that decision as to whether that patient should be certified or not. And it's also important to highlight here, we have the National Council for Persons with Disability. So it would also be very beneficial. This girl who's 20 years old said she doesn't want to go back to school, but she would like to start working. And I, explained to her what were the benefits of registering with the National Council, and one of them is tax benefits. So that could help her in terms of reduction in the amount of tax that she pays, gives her a little bit of extra money in her pocket when she starts working. So it's really important to think of the patient not just in terms of glasses, then what are you going to do optically, but can we certify them, and also the disability aspect of it. Now, if you see the patient at the bottom, I'd actually put some prisms there. Traditionally, this is what we were taught 25 years ago at university, that if you put prisms, you can actually, and the base out in the direction of where the visual field is limited, you can actually expand the visual field. Now, it doesn't always work, and you have to have Fresnel prisms with you. You have to have high 20 diopter Fresnel prisms to try them. They don't look great, as you can see. So I showed this girl. Initially, there was nothing wow that, oh, something has changed. So I've asked her to try it, and I said, look, if it doesn't work, she'll just peel the prisms off. But we just thought we'd give it a try. So there are lots of, other things that we can do, and this was just one of them. Dr. Nandasaba talked about the different optical devices that we have. We've been using this for many years. But nowadays, I find I'm doing less and less of the magnifiers, especially in younger patients, the optical magnifiers. And there's a reason for that, is because we have so much electronic magnification. All of us have a magnifier in our pockets, in our phone, in our tablet. So nowadays, patients don't even have to, even by the time they're leaving your clinics, you can already tell them about the magnifier that they have on their phone. They don't actually have to go and purchase something separately. So when they go, for example, you have a camera on your phone. When they go shopping, all they need to do is take a photo of that price tag that they can't see or the ingredients of the bottle. They just take a photo, look at it on their phone, and they enlarge it, and they get on with life. Some of us who are presbyopic, we've already started doing that anyway. So it's very easy to show our patients. Some of us, we go to the settings, and I'll show you that shortly, how you can actually make everything larger on our phones. So those are the initial tools that even before patients leave your clinic, for example, your optometrist could spend time just showing them what they already have. That's the first question I ask them. I say, can I see your phone? And when they show me their phone, I say, okay, this one we can work with 1, 2, 3, things like that. So the phone everybody has. Some people have tablets, okay? And if they have a tablet, that's great because, before we used to say, sit very close to the television, or we used to tell the, children or grandchildren for Christmas, say, can you buy your parents or grandparents a big, large television? You don't need to do that anymore. Today, if you want to watch Citizen Live or BBC Live, you can watch it on your tablet. So if you watch it on your tablet, you're already watching it at a very close working distance, and they can carry on doing that, and they don't need that far distance vision, which they possibly have lost. So again, the tablet is great for that. The tablet is great for downloading the Bible. Many patients say, they come in and say, I just want to be able to read the Bible. And others come and say, I just want to be able to do my M-Pesa transactions. But guess what? You can download the M-Pesa app on a tablet, and it's much larger than it would be even on your phone. Right? Some say, I can't do my bank transactions. They can now download all the bank transaction apps on their tablet. So it's about teaching them. And if they've got grandchildren, usually when they come in, you always do like a family conversation. And if they've got grandchildren will teach the grandparents and things like that. They can do WhatsApp. Many of the grandparents will come and say, they'll say, I have children or grandchildren in the US, for example, and I just want to be able to WhatsApp them. I want to do video calls with them. And so we show them how to use the tablet. There are other devices, as you can see on the top there, which is like the one that Dr. Nandasaba showed. It's just a little CCTV. So if any of the patients are very averse to technology and they say, no, I can't use technology, then we can sell them a CCTV device, which is just a little portable electronic magnifier that can make text as big as 25 times. But if you look at the bottom left-hand side, here, if you notice, we have reversed the text. So it is white on black. And glaucoma patients especially find this very useful, including macular degeneration, but I've also seen with glaucoma patients. If you just reverse the polarity, and that's what you can do that on your phone, you can do that on the tablet, you can do it on the CCTV devices, and you just show them that, hey, if we reverse it, can you read better? And suddenly they're like, oh my God, even that, N12 that they couldn't read earlier, which was black and white, they can now read that. So it's just using all these different techniques in the clinic that you can. So I'm doing a lot more of electronic even before I show them the optical devices. I've put only for iPhone because I'm an iPhone user, but the Android ones, you do the same thing. You just go into accessibility. And again, like I said, those who are presbyopes here on the group, this is really simple. Even if you want to avoid your +1s to start off with, if you're early presbyopes, then you can do this on, many of us do this on our phones. You go to accessibility, you click display and text size. From display and text size, you enable large text. You go to large accessibility, and right at the bottom here, you can actually just increase the size that you want. And everything on your phone will increase in size, whether it's your WhatsApps, whether it's your SMSs, your emails, everything just gets bigger. And you can set it based on, the person's visual impairment. So if we just, go and show them, then they feel really empowered. When I was in Malaysia and I presented at the World Pediatric Ophthalmology Congress for the Low Vision Symposium, this was one of the ladies from South America was there. And she was demonstrating this to us because, we're so used to seeing expensive products like the Orcam, like the one Dr. Nandasaba showed on glasses or Google glasses, etc. But you actually don't need anything expensive. The Seeing AI app is from Google and it's free. Well, nothing is free in this world. They're obviously collecting a lot of data from all our visually impaired people, and we'll probably use it for whatever next software or next big thing that we come up with. But for our patients, it's really good, especially in this part of the world. You can just download it. I had a patient from Congo, again sent to me by Dr. Nandasaba, and he was, I think I've got him further down in the presentation, and we made him, he couldn't read his currency. So now he came to Kenya, so he couldn't read the Kenyan shillings. He wanted to pay me in dollars. And I said, hold on, let's try, this app and you see. And it actually read it out for him, how many dollars he had and how much, he had to pay, etc. You could even convert it to French because he was French. He was mostly French speaking. He spoke a little bit of English. So you can even convert it in French. It can recognize people's faces. You go into the supermarket, it will read it out for you. He had a document that he needed to read overnight. He said to me, I need this document. I showed him just how to use this. It just converted the text into speech for him. And he was able to read the entire document. So it's really easy, really friendly. I've actually downloaded it on my phone so that anytime a patient walks in, we just take the patient through this. Of course, we have environmental modifications. For some of you who remember the work we did in Kikuyu on the left-hand side, this is the kind of environmental modifications we did for our clinic. We had tactile. We used a lot of contrast, as you can see, easy for the patient to distinguish the door from the walls, etc. Those, the bands there as well. So those are sort of simple environmental modifications we can do in our clinics or in our hospital facilities. Lighting is really, really important, but it needs to be task lighting, and it should be white light rather than yellow light, because yellow light gets very hot. Yellow filters are great, especially for them when they're struggling with night driving. When Dr. Nandasaba was talking about how they have difficulty following a line or the eyes get tired, then you can use these guides at the bottom. You don't have to go and purchase them. People can make them at home. You can have tactile for the microwave, so they know exactly where to touch, just to switch on and just do basic things in terms of the microwave. You can see at the bottom here, we always we talk to the family as well and say, look, if you're serving ugali, don't serve ugali on a white plate. Or if you're serving ugali, make sure there's sukuma on the side. Or don't serve fish on a white plate, but if there's fish, make sure there's spinach on the side, so that they can actually see what they're eating. So you can see here there's a better contrast in terms of the plate. So we educate the family. Sometimes husbands come with their wives, so we talk to the wives. Sometimes the wives come with their husbands. So we talk to the family. Some of them come with carers, with house help, etc. So we educate them at the same time. There are now these even bottle tops, a lot of tactile things that you can do. So it's one of the things we know with glaucoma patients is compliance with their eye drops. If we use these dropper sort of, little rings that they've got there, this can even tell you about how many times. So the 3, if it's twice a day or 3 times a day, different medications, some medication is once or twice a day, but it's really just using tactile information so that the patient doesn't miss out on their eye drops or pick up the wrong bottle when they're putting it in. So with glaucoma patients, I wanted to say, please think contrast. When we do visual acuity is black on white. That is high contrast. So you may get that 612 vision and you think, okay, this patient is okay. But in real life, they are really finding it difficult to cope. And that's because they can't cope with low contrast. And remember, we don't measure low contrast acuity. How many of us actually do it? I have to remind myself that I have to measure low contrast acuity in some of my patients. So it's good to have a contrast acuity test, especially in big clinics or big facilities. And you can see how stairs, just if you look at the normal vision, and on the right-hand side, if they have reduced contrast, very easy to miss the steps. But if they have put these yellow lines at the end, it's much easier for the patient to then figure out what is. Because remember, one of the things that glaucoma patients have is a risk of falls. And if they are elderly patients, then of course that causes other issues, other comorbidities as well. So if we can always think contrast for them, that will make a really big difference. These were all the things Dr. Nandasaba was talking about. What can we do with the bathroom? You can have rubber bands on, in different locations, have different contrasts. So the shower curtain is different to the color of the towels. They can have hand railings to prevent falls and things like that. Your floors, what you can do. Think about the kitchen. We talk about the kitchen, extra lighting, in terms of the spacing, stairs and steps. And one of the things I always used to, so when I started my first low vision training was it was almost 20 years ago. It was in 2004. And in Hong Kong is really built well. So this is one of the staircases in Hong Kong. And I didn't know what that meant. But if you notice, there is a tactile floor space here, the rectangular one at the top. So that tells the low vision patient they have come to the top of that staircase. Then everything else is flat and they go to the next one. Now, when they feel that next rectangle, they know now there's something else. Either I have to go up or I have to go down. So there's a lot of meaning to how this tactile information is provided, especially in public spaces. Bedrooms, what can you do? Entryways, what can you do? Orientation mobility for low vision patients for glaucoma patients specifically is very, very important because, as we know, the visual field gets constricted. There's a lot of counseling. This gentleman that I had from Congo, we did one session where he came with one colleague. We did a second session where he came with the same colleague, but now with another translator. And I have a feeling we're going to have to do a third session as well, because it takes a long time for them to either accept their condition, the situation that they are in, and also to accept all these things that we're saying, slow down when you're walking, you're going to need help. And they're like, no, but I'm okay. So you're constantly, it's a continuous process. It's not just a one consultation and that's the end of it. And then, of course, there's the role of the family and friends are really, really important. So it's really important that you have that time when you're working with these patients. Driving is a big question, as Dr. Nandasaba said, because remember, in terms of standards of driving in Kenya, there isn't really any, the laws may be there, the regulations, but there's no real follow-up. We don't have the responsibility to report them to anybody. If I was in the UK and we saw a patient, we had the responsibility to report them to the DVLA if we felt that the vision was not good enough for them to drive or didn't meet standards. So here, a lot of people drive, even if they shouldn't be driving. So we just educate them. We tell them to do different things like, just drive short distances, don't drive long distances, don't drive at night, drive on roads that you're familiar with. But then I will tell them about what it is in the West, what are the regulations, and that you don't meet those regulations. And look at what the regulations are. There's no significant defect within the 20 degrees of your central vision. And remember what we said, to classify them or to categorize them as low vision or visually impaired, they have to have less than 20 degrees. That means by the time the patient has already got less than 20 degrees, they really shouldn't be driving, even if their binocular visual acuity is greater than or equal to 612. So it's really, really important that we counsel them and try and make them safe for themselves. What I do tell them is that, look, it's also about your own safety as well as the safety of the other people. And hopefully the family members or the carers who are there will make sure that that message is delivered or that it is maintained. So this was one of the gentlemen that Dr. Nandasaba sent me, 62-year-old male. He'd actually had bilateral retinal detachments plus optic atrophy. One eye had been operated, the other eye hadn't been operated. So his right eye, he came in, his unaided was hand movements, left eye was no perception of light. But once I did a good refraction again, I got him to plus 18. With plus 18, he improved from hand movements to 6/240. And for him, that was a very, very big improvement. He felt that he could move around my office much more easily. He could see the door, he could open the door, and he wasn't bumping into things on the side. So just taking a patient, let's not underestimate taking a patient from hand movement to 6/240. So that's really important. And once I got him onto that, we then talked about all the electronic magnification. Because once you've got with 6/240, optical devices are not going to do much. So he's going to need O&M training. He's going to need environmental modifications, electronic magnification. And of course, we gave him a certificate of visual impairment and asked him to get registered with the National Council for Persons with Disability, and we'll continue working with him. This was a gentleman from Congo. He's very lucky. He works for a very big organization. They have, maybe 20 or 30 colleagues living in one block of apartments where they have cooks, they have drivers, and he can get to work and back from work. He can have a personal assistant to type at work. His unaided vision was right eye perception of light. Left eye was 2.0 logMAR, so 6/480, quite reduced. and I couldn't improve it on refraction. But with the electronic portable magnifier, he could get to N12. So he also used that to verify his dollars, when he was paying and things like that. At the same time as using the Seeing AI app that I trained him to use. So, different types of devices for different patients and what they require. Future treatments, what can we expect? So there's a lot of studies that have been done on how to stimulate the peripheral retina in glaucoma patients. There's obviously a lot of research that is being required. Some are using electrodes, some are using augmented reality and virtual reality as well to see how they can expand devices. Some of it looks promising, but of course there's a lot of research that is required. And that's just my references there. And otherwise, thank you very much.
Thank you. Thank you so much, Zara, for another very insightful presentation. And clearly, as you've said, we cannot underplay the importance of a good refraction in patients with low vision, because clearly that difference in 1 or 2 lines in visual acuity makes a whole difference for them. Also, it was good that you highlighted some of the simple modifications we can do in our daily lives, at home, at work, to ensure that these patients with low vision are also taken care of. And the role of AI, the world is moving to AI, so anything that comes with AI, I think it's something that all of us should be aware of and just be on the lookout how we can help these patients. I think it would be interesting to see how the visual stimulation, especially in glaucoma patient, unfolds and how it can be handy in helping these patients. I can see there are no questions in the chat box, but maybe I will ask a question. I saw Dr. Bitoko on the call. Maybe Dr. Bitoko, Dr. Gishange, either of you could respond to this. I'm just wondering, what are some of the efforts that are ongoing to help to strengthen low vision services in Kenya? And then also, I think for this forum, it will be good to just highlight about any training opportunities, because I know for us in government hospitals, we get so many of these patients referred to us for assessment for disability and then linkages with the National Council of People with Disabilities. And it will be good to know where to send these patients. And then for people with staff, whether in private or public sector, that would be interested in doing low vision to just strengthen these services, I think it will be good that you tell us where can we send our staff for these trainings. Dr. Bitok.
Thank you very much, Dr. Walaba, and to the 2 presenters, Becky and Zahara, for the great presentations they made. And probably before I even address the questions you asked, Dr. Walaba, I'd just like to say that this is a very timely presentation or discussion, and it aligns very much with the key priorities that we have as the eye health section at the ministry. We've been having a lot of discussions around low vision, and I think some of you in this group have been part of these discussions, including Zahara, who has been very resourceful in our discussions. So just to speak to what you asked, Brenda, some of the efforts that are ongoing. So number 1, maybe I can just highlight some of the key challenges, though Becky and Zahara had already spoken to that. So one of the issues, or one of the key challenges we have is that low vision services are not readily available, especially in the government hospitals, and patients have to be referred to the tertiary eye hospitals, that's Sabatia, Kikuyu, Tenwek, and Kwale, and even the private hospitals, including Gertrude's and the likes. So it's been a big challenge for patients who cannot access services in these hospitals, because these low vision services are not available in the government hospitals. But so some of the things that, some of the efforts that have been put into place, number 1 is on training. So a number of eye care workers have been trained on low vision. We have the low vision clinical officers. We have had some people trained through KSB and also Masinde Muliro University. So these, again, once they've been trained and posted to especially the government hospitals, they don't have access to the low vision devices, so they are not able to use the skills that they've learned, and still, so their skills with time rust. So the other thing that is happening in regards to training is that KSB has developed some short courses for those people who may wish to be trained on low vision, and they have customized trainings on low vision for the different cadres. We have training for nurses, we have customized trainings for clinical officers, and also for ophthalmologists. And this is used based on need basis. And the biggest consumer of this service has been maybe those counties that are supported by different INGOs. We also have training for low vision in KMTC. So we have the low vision clinical officers, advanced refraction and low vision, which has been there for some time. I think that is the biggest trainer now, but you also have a new course being introduced in KMTC called the low vision and assistive technology. And this one will target optometrists and even ophthalmic nurses, just in an effort to increase the number of eye care workers who can offer low vision services. Masinde Muliro also has a short course, a 3-month course on low vision and a 1-year course on low vision. And also they train the optometrists on low vision. Yeah, so the short course can be customized based on the target audience, and the training focuses not only on low vision, but also on the rehabilitation aspect. So these are discussions we are having, and Dr. Walaba, you've been part of these discussions. We had a meeting recently. So once this is well contextualized, then we can also share these for those who may be interested in having or in improving their skills on low vision. The other challenge that we have is the availability of low vision devices. These are largely not available in our government hospitals. And currently we have a project called the 80-Scale project. 80-Scale project focuses on improving access to assistive devices. That's for visual devices, physical disability, visual disability, hearing disability, and all that. And in the coming months, we'll be having some assistive devices for the visual domain or for visual disability being distributed to some of the county hospitals. And these will include the assessment devices for assessing low vision, as well as the actual low vision devices. So a number of counties, around 37 counties, will benefit from this. But the challenge, of course, usually is sustainability following the end of the project. But we hope we can find a way of ensuring sustainability and continuity of these low vision services. Maybe the other thing I'll add is that we are working on a low vision guideline, and yeah, that will be, once that is finalized, then it can be shared in all the platforms. It's really interesting to hear that there's a lot of innovations and technological advancements in terms of low vision, and I really like the slide Zahara presented on the electronic and computer assisted technology. And one of the things that Kenya Society for the Blind is doing is digitizing textbooks, the high school textbooks, so that even those students who have low vision can access the textbooks on the digital platform. So there's a lot of work going on in KSB, and there's a lot of effort being put in place just to try and address low vision services, but we still have major gaps. We hope this will improve with time. And the other area is a lack of comprehensive data on low vision. And probably I would like to challenge the members here that we can, it would be good to have research around low vision so that we can have data and so that the data can inform our decision making. Yeah, thank you. Back to you, Dr. Walaba.
Thank you so much, Dr. Bitok, for just enlightening us where we are at as a country and where we are heading to. And I think it will be very important to just strengthen these services across board in Kenya. There are a few comments in the chat box. So from Dr. Walia, for anyone with low vision, just get them mobile. Just getting them mobile makes the difference to the quality of their lives. Yeah, thank you for reminding us that. The other thing is low vision should be part of the comprehensive eye care. It should be introduced as part of training from the basic level, even as early as first-year residency programs. I believe we have so many educators on this call, both at the university level, KMTC. So it's worth noting that because we cannot avoid interacting with these patients as ophthalmologists. Dr. Jaffaji says, it's a question, who brings in the low vision aids in the country? And I think Zara has responded to that. I have imported low vision devices for wholesale. but I also believe KSB also sells. Yeah, I think I've had a number of patients whom I've had to refer to KSB, Kenya Society for the Blind, and they've been helped, they've been rehabilitated, and then they've also been given some of these devices. There are a number of partners who are actually partnering with KSB, as Dr. Bitok has mentioned, to help support the low vision services at KSB. Dr. Jafaji, super. The way we can deliver, we can definitely send them over to you. That's good. So yeah, Dr. Zara is happy to train optometrists. So we can always get in touch with her and then we can organize for that. If there are no any other questions, I think I'll hand over the meeting to Dr. Karagania so that you can just complete the remaining part. Thank you so
Walaba,
much.
I just want to say one point.
Yes.
You know, low vision has been given this sort of, it sounds like this big elephant, and it isn't. I want to say that it is so simple to do low vision assessments. As long as you have anybody who's doing a refraction, we can train them to do low vision. I can do it in the morning, in a coffee morning. That is how simple low vision is. I think in the past, for various reasons, we have made low vision sound really difficult, really challenging. But I just want to assure everybody on this call that it's actually so simple. It can take 1 hour of training to teach any of your refractionists how to prescribe a spectacle magnifier. We can do simple videos on how to use electronic devices. You don't even need an optometrist to do that for you. Your front office staff can actually train your patients. So what I want to say on this call is that we need to demystify low vision. We need to say it's really simple. You don't need a whole year course. I'm sorry to burst the bubble for some people, but you don't need a whole year course to learn low vision. And I agree with Dr. Walia that low vision should be integral in everybody's training. We don't need separate vertical courses. If optometrists have low vision in their 3-year program, that's enough. They don't need to now be going for a specialist training in low vision. That's how simple low vision is.
Thank you, Zara, for that input. I think we've all taken note. So I see we don't have any more comments or questions in the chat box. So Dr. Judy Karagania, you can take over. Thank you everyone for joining this CME.
Yes, good evening once again. Thank you so much, Dr. Zara and Dr. Nanasaba, for your presentations. Thank you for simplifying what you've already said seems like a big elephant to us, and we are hoping to, of course, first of all, gain a lot of interest and also just learn more. Just 2 announcements. One is that there's the SGM that had to be postponed from last month. It's going to be on Tuesday the 22nd at the same time of CMEs. That's from around 6:30. So the links will be sent. The link for the meeting will be sent to your emails. Kindly avail yourself because the matters for the AGM that were supposed to be concluded during the conference were not concluded, hence the necessity for the SGM. So kindly plan to attend that. And then we'll be having a financial literacy CME on Thursday the 24th, and details will soon follow once we have the poster. And yes, hopefully we will continue learning more about not just ophthalmology, but also how to build and secure wealth. That's it from us. Have a lovely Easter ahead. Have a good weekend. Safe travels to anyone that is traveling. And we will see you all on Tuesday. Thank you so much. Good night.